Il prossimo relatore è il professor Nicolas Pérez dell'Università di Navarra di Pamplona, che è in collegamento con noi. Nicolas, can you hear us?
Yes, can you hear me?
Perfectly.
Are you seeing my presentation right now?
Yeah, just a very brief introduction. Il professor Nicolas Pérez ci parla della malattia di Meniere nell'anziano, aspetti diagnostici e terapeutici, e vedrete è un otoneurologo drammaticamente brillante. If you want, you can start, Nicolas.
Okay, thank you, and hello to everyone. First of all, I want to give thanks to Giampiero for inviting me to this meeting. Unfortunately, my left eye didn't want to go to Italy, and I had to stay in Pamplona for a big problem I had in June and relapse this week. So I'm having intra-eye injections and laser treatment. So I was told not to take planes at least for a couple of weeks. So I want to thanks again also to him and to the non-solo meeting people that were making all the effort to take me to Italy. And again, it's a big pity for me not being there. I want to congratulate all you for the level of the meeting. I've been hearing yesterday and today the questions, the talks, and everything around. And I mean, it's so living the neurology you are doing there. That is a pity not being there, not because of the presentation, but also for the questions and for the good company all you make. Okay, so he asked me to speak on Meniere's disease in the elderly patient. And of course, I will say probably when the government tells you you have to retire, there are some issues that have to be for your attention before. That is the definition of Meniere's. What is an elderly person, and of course, if both items are relevant or not. We have very good definitions for Meniere's disease, whatever you want, the American Academy or the more recent from the Varani Society. They are very good for just to acknowledge that we are speaking of a very specific disease. And of course, all said before, in particular the talk before mine, on the geriatric domain must be taken into account when dealing with this kind of patients. However, what is becoming an elderly person, of course, there are going to be some points of attention in our life that are going to tell us that we are becoming elderly. However, we need some frame to move, and it is not clear if it is the 65, the 70, or even the 50 years old. What is an elderly person? These two papers are on the web, and one speaks on falls in elderly people. They are older than 65, but the other speaks on dizziness in the elderly men and is in the 50 years old. So it's not a big news for everyone, but I mean, it means that where are the limits? However, a very recent paper by Yuri Agrawal is suggesting that we have to probably go up in terms of vestibular system to the 70 years old. So again, this is an issue open for discussion, but however, just in terms of statistics, we still speak on the 65 years old. Is this a problem? I mean, is Meniere's disease in the elderly is a problem for us? And is the first question. Meniere's disease is a problem for everyone just here and in the room there. And of course, is the elderly patient a problem? So in Japan, it seems to be a big problem. And they say that they link this problem to stress in working. And we must remember that in Japan, if retirement comes, it comes very late. However, this is not a problem in Holland, and where the group of old persons has not grown so fast as in Japan. Retirement, of course, at 65, and of course in all these papers there's a kind of, which was the criteria for Meniere's disease, and the Japanese were used to make guidelines not very strict. Of course, at the end, defining the elderly and the problem is going to be a problem of lifestyle and life habits. How many patients with Meniere's disease, old patients, do we see? Well, it's not usual. I mean, it's almost as unusual as if you find an ear walking in the streets. But in the statistics, just if we put in the 65 years old, the limit is going to be 11 to 38% of all the patients that we see. Is it different after 65 years old? Okay, the statistics say that it's more frequent in the female than in the male, in males, and also there's some difference in the disease spell. So I went to our data. We have a database of patients that usually come once a year to the clinic just to make ENT, auditory and vestibular testing, for radiological evaluation, psychiatric evaluation, neurological, and so on, and psychiatric too. And I took the data from that population. They are 261 very regular patients, almost since 25 years are coming, and we see that they are when the disease began, it was on the 46 plus minus 13. That is a little bit younger than usually said. We don't see more men than women. So we look for what we should call de novo disease. I mean, Meniere's disease that begins after the age of 65. And we have just 8%. It's not as high as the 11%, but it's 8%. Of course, we have younger patients too. Our mean age to begin the disease is 46, and it's usually said is a little bit later, on the 50s. But this is the population we have. And we ask, okay, how disabled are these people? And we have two populations. Some of them, as you see in the lower part of the screen, are treated with medications, are followed up all this time, at least more than 2 years. And also we have patients with intratympanic gentamicin, and we are following them. And there is not a trend in the level of disability according to the functional level scale regarding age when they are treated on medication. But for patients we are treating with intratympanic gentamicin, we see that as they get older, they become more disabled. They are almost, there's a very good relationship between them, 0.029. So there's, of course, an increase in disability for these patients. I'm saying those that we should consider to give gentamicin. Is different the disease? I mean, are there any difference between them more than this kind of disability? Of course, we did not find the number of disease spells to be higher according to age for the intratympanic, neither for the medically treated. It is known that electrocochleography is becoming more positive with age, but however, the glycerol test is more frequently negative. And this dissociation is very typical of people in the elderly. And this is probably a hallmark of the disease at that time that probably is telling us something more on presbycusis. We see that marking crises are more frequent, of course, but the amount of people is very low. I'm telling you that we have 21 patients older than 65, and in them, marking spells are in percentage more frequent and significantly limit, 0.049 almost. Well, this is the type of recovery a young and an elderly patient has regarding posturography after a unilateral vestibulopathy, and of course it must be a musculoskeletal problem. However, do the existence of marking spells have any meaning in the treatment? As you can see here, this is I hope you are looking the same I'm looking. So on your left, we have the patients with the marking crisis, and on the right, we have the patients without marking crisis. In both of them, you can see that the treatment was a medical or gentamicin, and on the left, for both screens. But we don't see that the result of the treatment is going to depend on the existence of tumor marking spells. I mean, tumor marking spells exist. They will make us to probably take a decision on the treatment, but because of the tumor marking, the prognosis is not worse, it's not better. So it's not a problem to treat them when they have a tumor marking spell. How do we treat them? We have everything available for us, and we have to care for the efficacy versus side effects. And again, I want to link my talk to the previous one regarding the fragility of all these of these patients. What do we see in our pool of patients treated with gentamicin? We see that the younger the disease begins, the later we treat. There's a kind of difference that, of course, is very probably for everyone, but in the elderly persons, we do not wait so much to treat with gentamicin than in the younger patients. There's a problem with the treatments that makes the existence of another population. So we have a lot of patients that, I mean, those on gentamicin are 188, more than 2 years. But as you see here, 72% of them, disease began before 65 years old, and we treat them before 65 years old. However, we have an 18% that disease began before 65 years old, but we treat them after 65 years old. And we have a small amount, 10%, in which disease began after 65, and we treat them after 65. So when we speak on elderly patient, we have to speak on the elderly patient with the disease and the elderly patient being treated. It's not the same. Which were the results, or which are these patients? So we have in the upper part, well, we should call the trans limits. Disease began before 65, and we treated them after 65. And of course, we have those in the off limits that I would say that are those that disease and treatment was after 65. Both of them are having medication and tretinoin and gentamicin, but I'm going to look only for the gentamicin. We see that duration of the disease and lack of treatment is really higher for the trans limit, but is a little bit lower for the off limits. In some way, I would say here now that there's a trend to treat the patient earlier when you are younger and when you are elderly. But in those around the 50s, we wait so much. I mean, we are waiting a lot of time to treat them. Is this a special population on this pathology? I don't know, but it's our data, and this is very long statistics, almost 200 patients. I mean, which is the result? I mean, the result is the same. The number of patients in class A, the number of patients in class B, C, D, or E is the same. Whatever you are treated after the 65, beginning the disease before 65, or if you are treated after 65 with a disease beginning after 65, it's not a problem. It's the same. How do these patients compensate? We thought that probably these patients will be a little bit worse, but as I told you before, even tumor marking spells are providing a bad compensation. This is the 3 groups of patients. Just look to the one in the middle and to the right, the yellow, well, the orange, and the red. These are all patients, these are all class A patients. So these patients, after treatment, 2 years after, they never had any more vertigo spell. Okay, they are free of vertigo. And this is a visual analog scale in which we ask for instability, amount of instability regarding before the treatment. And as you see here, there's no worsening on instability. So a class A patient is a patient that is going to have no more disease spells and is not more unstable than we thought they could be because of the age. In conclusion, of course, there's a problem with definitions. I mean, what is an elderly patient? What is an elderly patient with a Meniere's disease? There's a bias in treatment. Of course, we are just looking for intratympanic gentamicin, and we treat them in just one shot on demand. It's not a protocol, a titration protocol. There's no rationale to treat them in other ways, than younger, but there are some red flags in the elderly. Of course, when I show you the data of the intratympanic gentamicin, the bias is mainly that when we decide to treatment, probably I don't know up to now, and we have not made a prospective work on that of how many patients that we were that you will say, I'm going to treat him with gentamicin, but I'm not going to treat him because he's an old person. Okay, this is a bias to the treatment. I mean, our decision to treat them is more careful than in the younger, probably. But however, not so much. There are no significant difference. So, which is the rationale for this? I mean, is the vestibular system working in another way when you are older than 65, or is working the same? And of course, there's a lot of papers now, and also it was said in the first talk about the video head impulse test and a new way to analyze the vestibular system. Of course, we are speaking of assessment of the vestibular reflexes, the vestibular ocular reflex and vestibular spinal reflex, regarding the video head impulse test and the vestibular myogenic potentials. And of course, I think that Leonardo is on the auditorium. I'm not going to tell about the relevance of his and the work with Ian Cotois on providing a good vestibular reflex examination. What do we know on the elderly person, normal elderly person? I mean, this is impressive. This was our first work on the normals. And if you see in the upper right side, well, we know that gain is going to lower 0.01 every year. And of course, the question of the saccades was there before. You see many saccades when you are older than 70. So it's a kind of, is probably 70 a hallmark of change in the vestibular system? It could be if you just look to the saccades. But if you go for the gains, of course, we have to be very careful on the velocity of the head, the velocity of the head impulse, also said before. And we see that the gain is going to lower in the very extreme age. These are the more than 90 years old patients. They were almost, I guess they were 6 between 90 and 97, 91 and 97. So only in those patients when the speed, the velocity of the head impulse was very high, then you begin to see how the gain is going low and low. But you see 0.8 almost normal. So isn't it rational to put the elderly vestibular system on the 65? I don't think so. Probably we have to think on almost 90. The extended work by the Australian group regarding the anterior and the posterior canal is there, and of course this is very stable gain almost to the age of below 90. Well, regarding saccades, it was just asked before. Of course, healthy people, older adults, make large cover and over saccades. And of course, it could be the hallmark of a small BUR gain deficit, or of course, probably that the saccade generating mechanism is not working fine and is impaired in elderly persons. That is on the pure central nervous system. We have to test these patients both when we see them. We have to test them saccades and smooth pursuit, and of course, there's a clear reduction on the amplitude, peak velocities, main sequence on the saccades as the patient becomes older, and the profile is much less skewed than in younger people. However, this is not the question on the smooth pursuit. BEMS, of course, we know that it's going to be a reduction in the amplitude and an increase in latency, mainly for the O BEMS, less for the C BEMS. But this must be regarded to the anatomical changes in the utricle and saccule. We know the number of photoconia in the utricle is going to be lower than in the saccule as aging comes, but the number of hair cells in the utricle are going to be much outnumber those in the saccule in elderly persons. So still, I think that the anatomical correlation is probably not so perfect because, of course, now we are speaking of hundreds of normal subjects up to the age of 97, but we have very small numbers of temporal bones of people becoming almost 100 years old. So in some way, still the anatomical records are not going to help our data, but in our data we see that, of course, the elderly situation is going to be before or earlier in both utricle and saccule than before in the semicircular canals. I mean, it's common to how the utricular and sacral function will decrease with age, and this is going to depend also on the way you also test the BEMS, is it acoustic or vibratory stimulation. But we may not forget that, of course, there are changes in the brainstem, there are changes in the cerebellum. It is not clear still in the vestibular nuclei what is going to happen on the amount of neurons, and of course there's only an increase, clear-cut increase, and this is no doubt, in the amount of the lipofuscin deposits in the young, an increase in young cells. At the cerebellum, of course, there's going to be changes of interest. Okay, and all of this for what? For spatial orientation, and spatial orientation is going to be influenced by hippocampus and the parietoinsular vestibular cortex, and all of that from the vestibular is going to be related to vestibular loss, and of course all of this is going to be related to dementia at that age. So in some way, and I think it's going to be the topic at the end of the meeting, I'm sorry not being there, but of course we have to link all the relevance of the vestibular system for what it is, that is for spatial orientation, for good visual acuity, for good postural reflexes. Probably we need to expand our work to test more than reflexes, of course, and this last message, to the dynamic visual acuity and to the postural reflexes in these people. And I think this is all I wanted to tell to you. And of course, I'm so sorry not being there again. I'm missing all the good friendship of all the people there. And I'm not going to give any particular name because I will make any mistake. Okay. I hope you have heard.
Thank you.
Thank you.
Thank you very much for the great presentation. Now there is time for some questions from the audience. Ci sono domande.
Nicolas, thank you. Thank you very much for your presentation, for your presence in Tech.
Oh my God.
Okay. One question for you. In your presentation, 8% of old age people have a de novo Meniere.
Yes.
But in these patients, the symptomatology is equal of the patients under 65 years or not? Because if they have a reduction of the vestibular function, maybe the symptomatology is very different, or not?
No, I think it's the same. No. In my opinion of what we have seen is that only they come more disabled, a little bit more to marking spells, and that's a big problem. But in the rest, they are almost similar patients. I mean, in vestibular, we have a problem with hearing loss, and that is number one. I didn't address in this talk, but I mean, it's because we have. I mean, we have to know that. But what I don't know, and I cannot give you a good answer, probably Marco and someone there will tell you about the dynamic visual acuity in them. Probably dynamic visual acuity is going to be much lower than expected. I mean, I think what we are going to see in the elderly patient is there's not a straight link between vestibular deficit and disability, be it in the vision, visual acuity, be it in posture. But I think in terms of disease is very much similar.
Ci sono altre domande dall'audience?
Okay. Thank you very much.
Thank you,
Nicolas.
Bye.
and enjoy.
Nicolas, see you the next year in Chieti. No, from Pamplona.
With the ophthalmologist.
Okay.
Go together.
Good luck. Good luck for your eyes.
Congratulations.